The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome to the next episode of TMD Demystified. I am Tony Urbanek. Today we're going to cover the place for surgery in treating temporomandibular joint disorder. Now, let me just repeat that. We're going to talk about today the actual use of surgery for the treatment of temporomandibular joint disorder. For those of you who follow me, know that I am an oral and maxillofacial surgeon, board certified, did major reconstructive surgeries of various kinds for 50 years here in Nashville, Franklin, Tennessee. But for the past 15 years, have not done any temporomandibular joint surgery because of the general results of temporomandibular joint surgery, the success of surgery on the temporomandibular joint. 15 years ago, I decided TMJ surgery, that is, surgery on the temporomandibular joint, was not going to be the long-term solution for this problem. Did the research, because of my broad research experience and background, I decided to see if I could find a better way to treat this problem non-surgically. And I did. Now, that's a different story, and we've covered that in many different avenues and on many different other podcasts. But today we're going to talk about the real place that surgery has in treating TMD. Even though I am not a proponent for surgery on the temporomandibular joint, there is a place for surgery, and that is what I'm going to explain. Last Sunday night, I wrote the parallel blog, written blog, that goes along with the today is Tuesday, podcast that I record, which is entitled, There is a Place for Surgery in Treating TMD. And I'd like to just read the first paragraph or two to get us going on this podcast today in explanation. There is a place for surgery in treating TMD, but it is not surgery on the temporomandibular joint. In the 1980s, just about every oral and maxillofacial surgeon was doing surgery on the temporomandibular joint in an attempt to help the thousands of patients who suffered from the symptoms of temporomandibular joint disorder. The textbooks, annual meetings, and journals were filled with chapters, lectures, and articles promoting one kind of surgery or another on the TMJ as the best way to make the symptoms disappear. That was the 1980s, and I was there. I was in the middle of it. Trained at Vanderbilt, finished my training in 1978, and came out into private practice, and did all of the new technological advancements that we had learned during that period of time. One of them was various surgeries on the temporomandibular joint. There were different types of surgery promoted as having advantages over other competitive types of surgery. There were surgeries to add things to the joint, and there were surgeries that remove things from the joint. There were surgeries that were done with direct visualization on the joint through an incision in front of the ear, and there were surgeries done through an arthroscope and visualized on a television screen as the surgeon manipulated his instruments through tiny puncture wounds. Over a period of the first 36 years of my career, I did over 2,000 temporomandibular joint surgical cases, half of them open joint cases through an incision in front of the ear, and half of them through an arthroscope. I had the experience of it all, and I did every type of surgery promoted and explained in those textbooks, annual meetings, and journal articles. There were surgery that tried to reconstruct the meniscus disc within the joint. And for the first 36 years of my 50-year career, I tried them all. There was one of these surgeries that was promoted back in the early 80s that used a material called Proplast Teflon. And for the oral and maxillofacial surgeons who are listening or viewing this podcast, you are, whether you're a young surgeon or an older surgeon, I am sure you are at least familiar to some degree with the Proplast Teflon debacle. Because it was a material that was highly promoted within the profession, approved and cleared by the FDA, promoted heavily in the journals, and when used over a period of time, and it was not discovered until it was used for several years, caused significant destructive effects on the temporomandibular joint. I was one of those surgeons. Over a period of roughly 7 years, I placed that material in 81 patients. 81 patients, I did surgery that placed Proplast implant material, some of them on one side, some of them on both sides of bilateral case. And after 1989, I spent the next several years removing all of this material because of its destructive attributes. Very destructive material. It was called giant cell inflammatory response. These large giant cells, inflammatory cells, kind of like mast cells, but more destructive, would literally eat away the bone and eat away all portions of the temporomandibular joint, not only the condylar head, the ball part of the socket, but the condylar or the glenoid fossa portion, and in some cases, fortunately unusual because we tried to get it out as early as possible, would actually penetrate the brain case and allow access from the temporomandibular joint into the brain case and the brain. And I had seen a couple of my cases like that, but I was one of hundreds, if not thousands, of surgeons throughout the world, and especially in the United States of America, who used Proplast Teflon during that period of time and then spent years removing it. That change, that was a watershed change in the use of any kind of implant within the temporomandibular joint. And although the FDA had approved this material to begin with, it had looked at the science and given it clearance to be used. The FDA never took responsibility for their part in this. Of course, the government never takes responsibility for it. And the responsibility fell on the manufacturer, who went bankrupt, and throughout the United States, the responsibility fell on the surgeons who used it. And I, as a surgeon, was able to justify what I had done. Not that it was the correct thing to do, but that I had followed the protocol and done exactly what the manufacturer and company had designed the Proplast said how it was to be used, exactly why it was to be used, and followed the package insert. But that cleared my name, but it did not clear my attitude toward temporomandibular joint surgery in general. And it was about that time that I began to be very suspicious of all types of temporomandibular joint surgery. And then it took a few more years for me in testing out many, many different varieties of surgery to come to the conclusion that surgery in general was not going to be the long-term solution in the best interest of patients. And in previous episodes, I have talked about the meeting that was called in 2018 in Washington, D.C., and at the National Academy of Science, Engineering, and Medicine, where all of this was brought out again and discussed in an attempt, with a major attempt, to stimulate research on temporomandibular joint problems. And again, since that time, the results have been published in this volume on the priorities for research and care on temporomandibular joint disorders, Consensus Study Report, 2018, National Academy of Science, Engineering, Medicine. And basically, not a whole lot has been done, if anything. There have been funded some studies. I've given viewpoints from the Association of Oral Maxillofacial Surgeons, and a representative of that meeting, who defended the use of total joint reconstruction in many different varieties, and admitted that different types of arthroplasty, or that's a generic word for general surgery on the temporomandibular joint, no matter what kind of surgery, arthroplasty, had various problems, which I had come to the conclusion with many years before 2018. So that set the picture for our current situation, and my statement that there actually there's a place for there is a place for surgeons in treating temporomandibular joint surgery, but it's not on surgery on the joint itself. And so here's what we have found. There are three causes. There are three causes for damage to the temporomandibular joint, generally speaking. And they are bruxism, clenching and grinding the teeth, overuse of the joint, overuse of any joint, hip, knee, elbow will damage a joint. The TMJ is no different. If you overuse the TMJ with bruxism, clenching or grinding, whether it be night or day, whether it be clenching or grinding, they're two different motions, but they do the same thing. They overload the joint, and an overloaded joint will break down and become inflamed. What I discovered was inflammation creates the symptoms directly. So if you can make the inflammation go away, the symptoms go away. The second cause of damage to the temporomandibular joint is acute trauma, motor vehicle accidents, athletic accidents, bar fights will damage the temporomandibular joint. And if damaged enough, it won't go on to healing. It creates chronic inflammation, and chronic inflammation creates the symptoms. And the third and most important for our discussions today is functional malocclusions. Now, it is the area of orthodontists to usually fix malocclusions, but we're not talking about the general aesthetic kind of malocclusion that patients see and doctors see and dentists see, where the teeth are not aligned perfectly, and that is a very appropriate area for the orthodontist to get involved to straighten teeth. But there's a much larger type of malocclusion that we call functional malocclusions. And functional malocclusions will actually, over a period of time, overload the temporomandibular joint, just like bruxism or acute trauma, overload the joint, create damage, which creates inflammation, which, if it does not go on to heal, will create chronic inflammation, which creates the symptoms directly. So, a functional malocclusion really is a growth problem of the jaws. A growth problem of the jaws is a functional malocclusion. Everybody on the planet has two bites. They have a bite where the teeth have learned to mesh together well, either with or without the help of an orthodontist. The teeth mesh. And the second occlusion is the occlusion where the ball fits in the socket in the best way. But if there is a significant difference, or can be a small difference, but a change in position that is significant enough between bite 1 and bite 2, where the ball fits in the socket of the jaws, that difference is called a functional malocclusion and needs to be corrected. It needs to be corrected. It can't be corrected if it's significant enough. It cannot be corrected with orthodontics alone. You need the help of an orthodontist for sure. You need orthodontic assistance, but the actual treatment itself will necessitate some surgery on the jaws. We call that surgery orthognathic surgery. And for the uninitiated, for our oral surgeons who are witnessing this podcast, listening to this podcast, you'll know all about orthognathic surgery. For the dentists who are witnessing this, viewing this, you probably know little to nothing about orthognathic surgery, and certainly for the public, patients, you have probably no idea what orthognathic surgery is. Orthognathic, by the way, are just two Latin terms meaning straight jaws. Orthognathic, ortho, straight, gnathic, jaws. Straight jaw surgery to straighten your jaws. So to give you an idea of what this is, I thought I'd share just a very brief video that I picked off of YouTube. I have given the credit to the producer of this. Hopefully we won't get it done because I show you this, but it's just a, 2-minute video of exactly the general nature of orthognathic surgery and how it plays into the overall treatment of temporomandibular joint problems. So let me share my screen to begin with and see if we can play this, and then we'll talk about it a little bit, see what happens here.
Corrective jaw surgery, or orthognathic surgery, is a group of procedures performed to correct dentofacial irregularities, most commonly manifested as misalignments of the jaws. These deformities not only cause malocclusion or bad bite, but also create problems in the temporomandibular joint, the TMJ, and the airway, resulting in difficulties chewing, swallowing, speaking, and breathing. While the surgery is performed to correct functional problems, patients' appearance may be dramatically improved as a result. Open bite is a condition where the upper and lower front teeth do not touch when the mouth is closed or at rest. An open bite can lead to a number of oral health conditions, including tooth wear, tooth breakage, and TMJ disorders. It may also cause speech problems, known as lisping, in some individuals. Open bite surgery involves removing some of the bone of the upper jaw to move it to a new position. Once the jaws are aligned, plates and screws are used to secure the bones in place. Protruding lower jaw is corrected in a procedure called mandibular setback surgery. The tooth-bearing portion of the lower jaw is separated from its base and moved backward for proper alignment. In a similar way, receding lower jaw, or weak chin, is corrected with mandibular advancement surgery. In this case, the tooth-bearing portion of the lower jaw is repositioned forward. Orthognathic surgeries are commonly performed in combination with orthodontic treatments and may take several years to complete.
All right, so that was just a very brief, quick review of what orthognathic surgery is about. There are variations on each one of those surgical movements. You can also vary the vertical height of the lower face, or even get into the mid-face, depending on the facial growth and development of the patient. And that is the problem. The problem with functional malocclusion, it's a problem with facial growth and development. And this is one of the primary causes of joint damage and temporomandibular joint disorder when the joints become damaged due to functional malocclusion, and it needs to get fixed with the assistance of an oral or maxillofacial surgeon who knows how to do orthognathic surgery. Not surgery on the temporomandibular joint, but surgery on the jaws to remove the cause of the overloading of the joint. Very simple concept and very effective. It has to be used in conjunction almost always with orthodontic assistance, And the cases to perform this will usually take, because most of the time the work will be done in preparation for the surgery. The surgical event is a very brief surgical event, but in preparation usually takes between 12 and 18 months of orthodontic preparation, so that when the jaws are moved into their proper positions, all the teeth fit together. And then there's usually a little bit of orthodontic finishing after the jaws are moved, and then you're done. And now you end up with a much improved bite where you do not have a functional malocclusion. The two positions of the jaw, centric occlusion and centric relation, where the ball fits in the socket, are either identical or much closer together where the patient can tolerate that difference. And as you saw in the diagram and you saw in the cartoon video, the facial profile, the facial appearance is much, much improved. And of course, there isn't any further damage to the temporomandibular joint. And if necessary, sometimes you do need to continue to unload the joint if the patient is a clencher or grinder, and unload the joint with a orthotic device that unloads the joint. And usually at that point you can get by just wearing it nighttime only. That device, as you know, is called the Urbanic device and protocol, which unloads the temporomandibular joint to allow any resistant or continued inflammation to decrease or diminish. So it's a combination of orthodontics, surgery, and after surgery, occasionally, usually about 50% of the cases, no further orthotics are necessary, and about 50% of the cases, a continued use of one of these orthotic tools, usually worn just nighttime only, will handle any residual inflammation within the temporomandibular joint. So that is why there is actually a place for surgery in treating TMD. And for my oral and maxillofacial surgery colleagues out there, I would encourage you to continue, if you're young, to learn and continue to do these procedures, because it's very important to treat temporomandibular joint disorder in the proper way. With this as a preliminary description of the place of surgery within the temporomandibular joint, I don't have any further comments on it, other than for patients who have a problem, a facial growth and development problem that sometimes can be seen very obviously by the appearance of the face. And if you have a setback lower mandible or a large forward position of the mandible, that's called retrognathic mandible, or protrusive mandible, prognathic mandible. You can see it in vertical changes of the face where patients will smile. I saw one of those yesterday. Patients would smile and the upper lip went up, and you could see all of their teeth and all of their gum tissue underneath their nose. That's a dead giveaway. You have a vertical hyperplasia, too much vertical growth of the lower third of the face. You see, my experience, my training was heavily weighted toward facial growth and development. I actually was a fellow with the National Institute of Health, National Institute of Dental Craniofacial Research for 2 years, doing independent research on facial growth and development before I ever finished my full training and came out into private practice as a maxillofacial reconstructive surgeon. So this is not new to me. All right. With that said, hopefully this will clear up a few questions or confusions. That's the whole point of TMD Demystified, to clear up some confusions regarding the diagnosis and understanding and treatment of temporomandibular joint disorder. Remember, it's just one disorder. It's chronic inflammation. It has many, many symptoms. It has many, many disparate symptoms that to the physicians don't make any sense. Earache, jaw pain, neck pain, ringing in the ears, upper back and shoulder pain. But those are all well documented symptoms of temporomandibular joint disorder. Migraine headaches, so many patients have been treated for migraine headaches where the headache is actually originating from chronic inflammation within the temporomandibular joint, causing all the muscles to get tight to hold the joint motionless. That's where the pain originates. The body says, hold this joint motionless, pulls on the bone and gives you a big old long headache that's misdiagnosed as migraine headaches, where it's actually originating from the temporomandibular joint. Until next time, hopefully this is helpful. Hopefully this will make some sense to you. Hopefully, to one degree or another, this demystifies temporomandibular joint disorder. I am Tony Urbanek.